Okay, let's unpack this. Have you ever wished there was, a shortcut to becoming truly well-informed on a complex topic?
Especially one that impacts all of us, like healthcare transformation.
Exactly. Today, we're taking a deep dive into an incredible 4-year journey, one that aimed to revolutionize healthcare across the entire Midwest.
Yeah, this wasn't just another initiative.
No, not at all. We're talking about a groundbreaking project that applied innovative thinking, network science, and behavioral economics to really transform clinical practices.
Mhm.
It's a story packed with ambitious goals, some really unexpected challenges, and honestly, some truly surprising successes.
And what's fascinating here, I think, is how they leveraged the scientific insights, really deep insights to tackle real-world problems in healthcare delivery,
Right.
moving beyond those traditional kind of rigid models to something far more adaptable, more patient-centered.
We'll be exploring the insights from the sixth section of the Agile Network, a book by Dr. Malaz Boustani. He's a professor at Indiana University, alongside his co-authors, Dr. Richard J. Holden, Dr. Jose Azar, and Dr. Craig A. Solid.
A really strong team there.
Definitely. Get ready to discover how a network of dedicated individuals transformed healthcare on, well, a massive scale.
Yeah, it's quite a story.
So let's set the scene. The Great Lakes Practice Transformation Network, or GLPTN. It wasn't just another initiative.
No.
It was intentionally structured using cutting-edge insights. We're talking network science, complexity science, aiming to connect local communities of clinicians to state-based hubs.
And if we connect this to the bigger picture, that structure was really designed to help good ideas spread
Yeah.
quickly, effectively.
Like evidence-based innovation.
Exactly. Starting local, but then spreading throughout the whole network. A very organic way to scale change.
And their goals were nothing short of audacious. I mean, they aimed to transform the practices of 11,500 clinicians
11,500. That's a lot of people.
across Illinois, Indiana, and Michigan, impacting the health outcomes for over 10 million Americans.
Wow.
And get this, their commitments included reducing 410,000 unnecessary hospitalizations.
410,000.
Yeah, that's more than 8% of the national target set by the Transforming Clinical Practice Initiative, TCPI, that federal program trying to change practice delivery nationwide.
Right, I know the one. That's a huge chunk.
It really is, and they were looking to generate anywhere from $1 to $4 billion in cost savings for the federal government.
1 to 4 billion. I'll
Okay.
talk about big numbers.
It really raises an important question, though. How do you achieve such a massive scale of change with what was, in relative terms, an incredibly modest budget?
Right, what was the
They
figure?
estimated the cost at roughly $4,332.67 per clinician over 4 years,
Per clinician, over 4 years. Yeah.
which is a remarkable figure for the amount of transformation they envisioned. Really speaks to the efficiency they were aiming for.
Okay, so how did they plan to pull off these ambitious goals on that budget?
The GLPTN leadership developed something they called a minimally specified plan.
Right, not a rigid top-down mandate.
No, it was more like a flexible framework coupled with timely, actionable, and this is key, non-judgmental feedback loops.
And what's fascinating here is that focus on continuous monitoring and adjustment, like constant learning.
Uh-huh.
They prioritize reflection, to make necessary changes in iterative, rapid, and locally sensitive ways, truly embodying that agile approach, adapting as they went.
So the network itself, it had a pretty robust structure, right? A board of directors, state-level ops teams.
A central network team, yeah, and a consortium of faculty experts.
Right, covering various health domains. But crucially, they also included a stakeholders advisory board.
With patient and family representatives.
Exactly, ensuring the parent voice was absolutely central, which isn't always the case.
No, unfortunately not. It's a critical piece they got right.
And they were smart about leveraging existing resources, too. Regional health information exchanges for data.
Regional extension centers for getting clinicians enrolled.
And the intellectual capital of 6 medical schools to train their quality improvement advisors, their QI advisors.
Yeah, they didn't try to reinvent every wheel. They built on what was already there.
Smart.
Which brings up, how do they bring all that diverse expertise together, make it usable?
Good question.
Well, they developed a transformational change toolkit.
Yeah.
And it integrated 3 powerful approaches.
Okay.
First, those insights from network and complexity science,
Yeah.
behavioral economics we mentioned. Second, Lean and Six Sigma process improvement tool.
Plum manufacturing, right. Focused on efficiency.
Exactly,
Yeah.
cutting waste, streamlining processes. And third, a really strong focus on patient-centric, personalized population health management. making sure care fit the individual within the larger group.
So a really comprehensive toolkit.
Very holistic, yeah.
And their QI advisors trained in this toolkit work directly with practices using something called a practice assessment tool, or PEDO.
The PKT. It was used to gauge readiness, track progress, scored on a 0-3 scale for different milestones.
But not like a grade.
No, not as a judgment. More as a conversation starter, to figure out a personalized transformation plan for each practice. That non-judgmental feedback loop was vital for building trust.
Absolutely crucial. Okay, so that's the blueprint. What did this actually look like in action between 2015 and 2019? What were they doing on the ground?
Right, the activities. Well, they rolled out individualized lean training programs, especially helpful for smaller rural practices to build up their operational capacity, eliminate waste.
Things that maybe seem simple but make a huge difference day to day.
Oh, absolutely. And they provided crucial assistance with federal quality monitoring, like the Merit-Based Incentive Payment System, MIPS.
Yes. MIPS, always complex. Performance affects payments, right? Bonuses or penalties.
Exactly. It's a big deal for practices and often confusing. So GLPTN offered educational sessions, even clinical office hours for direct help.
That must have been incredibly valuable.
Hugely. Another key activity, connecting back to the network science bit, was identifying and engaging clinical champions.
The hubs, the influencers.
Precisely. Those high-degree nodes within the network. Specialists, maybe pediatricians or cardiologists, who were well-connected and respected.
And using them to spread ideas.
Exactly. Vital for quickly diffusing new ideas and encouraging adoption. They were like super spreaders for best practices. Very strategic.
Makes sense. They also held quarterly in-person networking events for the QI advisors.
They did, and specifically in person, because they knew the importance of frequent, repeated interactions for sharing what works.
Yeah.
Building that community.
That face-to-face connection.
Can't beat it sometimes.
And this is where it gets really interesting, I think. Indiana University deployed something called the Innovation Forum.
Ah, yes, the forum.
Tell us about that. It sounds unique.
It really was a group-based problem-solving platform. Brought together a really diverse group, nurses, admins, doctors, importantly, patients and families too.
All focused on solving real-world challenges.
And it had this very specific time-box format. Very structured, like 30 minutes networking, then a 10-minute challenge presentation, just 5 minutes for clarifying questions, no solutions allowed yet.
Okay, holding back the ideas.
Right. Then 45 minutes focused purely on discussion and generating solutions, and finally another 30 minutes closing networking.
So very focused, very efficient, like a mini hackathon for healthcare problems.
Pretty much, designed to generate actionable solutions quickly.
Okay, so lots of activity, innovative methods. What about the results? Did it work?
Well, let's look at the numbers. As of June 2019, they'd enrolled over 18,000 providers.
18,000.
With over 10,000 active members and over 3,500 who had graduated, meaning they met key transformation milestones.
And what about the types of practices? Was it just the big players?
No, and this is really impressive. A whopping 89% of the practices had 15 or fewer clinicians.
Wow, so mostly small practices.
Exactly, and 95% served rural or underserved populations.
That's incredible reach, getting into the communities that often get left behind.
It really is.
Yeah.
And the numbers comparing their initial commitments to what they actually achieved, they're pretty stark.
How so? Did they meet the goals?
They didn't just meet them, they significantly overachieved in many areas.
Seriously? Be quiet.
Okay, so target was 11,500 clinicians enrolled. They got over 13,700.
Yeah, nice beat there.
Clinical quality measure improvements, they achieved nearly 1,972,949 to be exact.
Almost 1 million improvements. Incredible.
Savings. Projected $1 to $4 billion, they generated over $1 billion. 1,719,847.
Crossed the $1 billion mark.
And unnecessary hospitalizations. Target was 410,000 reduction. They reduced over 62,000, 62,590.
Okay, so maybe not the full 410K, but still over 62,000 fewer hospitalizations is huge.
It's still a massive number, absolutely. And overall, this overachievement, it just demonstrates the immense impact of their Agile approach, the power of that adaptive network design.
It really validates the whole model, but I mean, it couldn't have all been easy. There must have been roadblocks.
Oh, absolutely. It wasn't all smooth sailing. They faced significant challenges.
Like what?
Data collection was a big one, especially with electronic health records, EHRs.
Ah, the EHR challenge. Familiar story.
Right. difficult for small and mid-sized practices to navigate, often led to erroneous reports, or they had limited choices for the quality measures they could even report on.
Yeah, vendor issues, fees, lack of the right reports. It really hampers improvement efforts.
Definitely. And this raises that important point about old systems kind of persisting. Interoperability was still a struggle.
Systems not talking to each other.
Exactly. Even certified EHRs often weren't built to easily support the kind of advanced quality reporting GLPTN needed. It limited data transparency, care coordination.
Did they try workarounds?
Yeah, they tried things like connecting practices to population health tools, using health IT advisors. But costs and just resistance to change were often barriers. It's hard to shift ingrained habits in tech.
Sure is. What else?
The transition to alternative payment models, APMs, that was another major hurdle.
Those new ways of getting paid based on quality and value.
Many small independent practices feared losing their autonomy. Or they just didn't have the resources, the staff, the capital to join.
And maybe some mistrust, too.
Yeah, there was often a pervasive negative connotation. Seeing APMs as just rigid programs, not a better way to structure care and payment.
So how did the network tackle that resistance?
What's fascinating here is how they addressed it. They created tools to empower the practices, like a readiness assessment, specific questions they could use when talking to APM reps.
Helping them navigate it.
Giving them agency.
Exactly. And those innovation forums, they became crucial. By bringing everyone together, they could really outline the financial value of APMs, build clinician buy-in, even engage legislators on things like creating navigator rules.
Using that collaborative platform again. Smart.
Very.
Even the QI advisors coordinating across 5 states. That must have been tough. It was. Challenges with shared tools, resources, feeling connected. But those in-person events, they really helped build that sense of community and shared purpose.
And just the sheer amount of documentation, tight deadlines, that adds up.
Absolutely. Constant pressure.
So, okay. We've seen the ambition, the methods, the amazing results, the bumps in the road. What does this all mean? What's the big takeaway?
Well, I think the 4-year journey of the GLPTN is just a powerful validation of this whole Agile network framework. Full stop.
Right.
It showed that by really embracing complexity science, network science, behavioral economics, focusing on collaboration, timely feedback, adaptable solutions, transformative change in healthcare isn't just possible, it's incredibly impactful.
It can actually be done on a large scale.
Yes. And if we connect this to the bigger picture, this model points towards a healthcare system that's more decentralized.
Moving away from just big hospital centers.
Yeah. Making evidence-based care accessible locally, right in the community. A personalized experience that really maximizes patient outcomes by leveraging how people naturally connect and behave.
And the work isn't stopping, right? Indiana University is expanding this.
That's right. The legacy continues. They're now aiming to recruit over 22,000 clinicians across even more states. Florida, Kentucky, Illinois, Indiana, Michigan, Ohio.
Wow, expanding the footprint significantly.
With a keen focus on vulnerable populations, underserved communities, working with community coalitions.
That focus is so important. Imagine a healthcare system where patients like Tommy, you mentioned his story, fueled the author's passion.
Yeah, a story of missteps, fragmented care. The kind of thing that motivates this work.
Imagine patients like him receiving personalized, evidence-based care with compassion, with trust, right in their own community.
The GLPTN showed it's not just a dream.
No, it's a tangible path forward. You can feel how personal this is for the authors, seeing the need firsthand. And now, this raises an important question for you, our listener. Given the insights we've shared about how these agile networks operate, how they foster community, leverage human behavior for positive change, how might you apply these principles? How could you make a difference in your own sphere, whatever that may be, helping to build a better healthcare future for everyone?
It's a powerful question to consider. How can that ripple effect start with you?